forum, Expanding Mental Health Access and Services Through Telemedicine. I'm Alison Elsner. I'm CEO of the San Bernardino County Medical Society. I'm also the chair of the IECHI, or the Inland Empire Community Health Initiative. And as you know, our coalition ensures that all families and residents have access to affordable, quality, and culturally sensitive health care in the Inland Empire, including both San Bernardino County and Riverside County. You can always find more on the website at iechi.org, IECHI.org. And please follow our Facebook and Instagram pages for events and project updates. Just a couple of quick notes, if you would be so kind as to keep yourself on mute when you're not speaking. And as we go through the presentations, we're going to hold all the questions till the end, but go ahead and enter your questions into the chat feature so that we can get to those towards the end of the presentation. And we can also open it up to verbal questions via raised hands as well. So I'm going to do something here. I'm going to introduce all of our presenters very quickly, so then we can just move through the presentations, okay? So first of all, I'm Alison Elsner, and I am going to be filling in with a short presentation on the federal legislative updates regarding telemedicine and mental health. And I'm filling in for Elizabeth McNeil, who is Senior Vice President for Federal Government Affairs with the California Medical Association. And she apologizes. She contracted a horrible case of walking pneumonia. So we didn't want her to exert herself any further and put her health at risk. So I'm going to be filling in for her. And just real quickly, as you know, as we mentioned, I'm with San Bernardino County Medical Society. I worked for many years in government and the political world for U.S. Senator and 2 California governors, both parties, mind you. And I'm previous CEO of United Way of the Desert. I've been with the Medical Society since 2015, and it is a component of the California Medical Association. David Seigler, M.D., is the chair of the Behavioral Health Department for Arrowhead Regional Medical Center, or ARMC. He received his Doctor of Medicine degree from the David Geffen School of Medicine at UCLA in 2011. He completed the UCLA San Fernando Valley Psychiatry Residency in 2015, where he also served as the chief resident of inpatient psychiatry. Dr. Seigler joined the ARMC team in 2019 as vice chair of psychiatry and soon became the interim chair before accepting his current role. He is currently an assistant professor at California University of Science and Medicine, the medical school adjacent to the ARMC campus. And we're also excited that Dr. Seigler is the newest member of our District 2 delegation to the California Medical Association for the House of Delegates. So welcome, Dr. Seigler.
Yep.
Evangeline Alpogianis, did I say your name right, Evangeline? Okay, is a senior consultant for Guidehouse's state and local government practice and serves in roles focused on implementing strategic initiatives and operational improvements for government organizations in the county, state, and municipal levels. For Riverside County's multi-year broadband strategy project, Evangeline leads outreach efforts for stakeholders statewide, including community-based organizations, cities, and county departments to promote digital equity and affordable internet. Welcome, Evangeline. Sophia Pan is also co-presenting with Evangeline today. And Sophia is a managing consultant for Guidehouse's state and local government practice. She led the development of the state of Washington's broadband equity access and deployment and digital equity plans, and she's excited to be working with Riverside County on developing a digital inclusion strategy. Welcome, Sophia. And last, we have Maria Savala-Mahany, Master in Education and licensed marriage and family therapist in California, and a licensed professional counselor in the District of Columbia. Maria has over 27 years of experience directing client care and operational programs in diverse settings. Maria specializes in anxiety, depression, and women's issues and has won several awards. She is skilled at cultivating high-performing teams, developing productive client and community relationships, and has expertise with several EMRs. Maria has also worked as an adjunct professor at Chapman University and is the owner of SoCal Health Consultants and the author of 3 books. Wow, welcome, Maria. We've got a powerhouse team here today. So, all right. So I'm just going to get started, as I say, with a little bit of framing the issue here and presenting a bit of some of our federal updates. As we all know, during the COVID-19 pandemic, federal and state health policies allowed a lot more flexibility, especially for Medicare and Medicaid beneficiaries, and started opening up what they were permitting with regard to telehealth care for mental health, especially. Unfortunately, many of these flexibilities that enabled a lot of the innovation and growth in telemedicine have continued only quote unquote temporarily, especially since the federal emergency declaration ended in May of 2023. And the US at the congressional level, anyway, has not made permanent decisions about telemedicine policy. There are a lot of legislative measures out there, especially at the congressional level, and many of us continue to advocate on behalf of our organizations, on behalf of patients, for increased equity to expand and extend these telehealth waivers. They're doing pretty well on the private insurance side, which has also allowed for more funding. But the as far as Congress is concerned, beyond what was extended until the end of 2024 through the Consolidated Appropriations Act of 2023, which has allowed extensions for Medicare recipients, as well as rural health clinics and federally qualified health centers, as I say, until the end of 2024. There's nothing really permanent in place after that. And there are a couple of reasons for that. Number one, we can probably guess what that is. It's funding, right? Centers for Medicare and Medicaid are, working with Congress. They have to try to stay within certain budget confines, despite how beneficial this is and how strongly many of us are advocating for the expansion of permanent telehealth and telemedicine waivers, and particularly with regard to mental health, because it improves healthcare. But lots of folks are saying they need more time to study this and, kind of evaluate the outcomes with this. And there are also concerns about abuse of the system. So they want to ensure that there are proper oversights in place for this. So I'm going to share a quick slide deck here. Can you all see this? Can you?
Not yet.
No?
Not
okay,
yet.
not yet.
Yeah.
Okay. All right, let's see if I can figure out how to get so we can see it. How about now?
Yes.
Yay. Okay, cool. Oh yeah, and let me do, so it looks good. Well, now I can't figure out, Janice, how to make it appear. So you guys are just gonna have to look at my slides on the side, sorry. Okay. So basically, what we talked about during the pandemic, Congress created Medicare telehealth legislation, and this especially expanded the audio as well as video services, and it waived a lot of the rural, geographic, and originating site telehealth restrictions to expand access to care, meaning that the patients did not have to go into a physical physician's office or a hospital or a clinic setting. They could do this from their home, because folks with a lot of comorbidities and concerns like that, and with regard to patient safety and physician staff safety during the pandemic, it was very necessary for a lot of these folks to remain in the home. As we talked about in December 2022, those waivers were extended through the Consolidated Appropriations Act, and they're set to expire, this December 2024. Several bills have been introduced to permanently extend the COVID pandemic telehealth waivers. HR 4189, which is S 2016 Connect for Health, and HR 7623 with Senate Bill 3967, the Telehealth Modernization Act. And there are some other things included in there, such as in-home services and some addendums to that, which are all beneficial for health equity, especially with regard to mental health. Recently, the House Ways and Means Committee did pass comprehensive telehealth legislation to extend the waiver through December 31st, 2026, 2 more years. Okay, so that's just been passed through committee. All right, so we're in the 118th Congress right now, which is a 2-year cycle. It ends the end of this year. So we are hoping that passes the full Congress. We are all lobbying heavily for this. Another update, another piece of legislation preserving telehealth, hospital, and ambulance access Act has some similar provisions that we're trying to get through there. HR 8261 specifically provides, I'm sorry to read this all to you, you guys can read, but basically it's an extension of that exemption, especially again with referring back to that originating site and those restrictions. So patients in rural areas without transportation can receive telehealth services. And from those inside the home or wherever they can access a telecommunications system without being forced to travel to that brick and mortar location, like we talked about. It also would ensure a continued moratorium on the requirement for an in-person visit within 6 months of a Medicare beneficiary receiving the first telemental health service. And then the audio authority to provide audio only, because a lot of elderly or technology challenged folks, they can't get on a computer. We know that. This is something our marginalized populations deal with all the time. And I see our colleagues from the broadband office nodding to that. I'm sure it's something they deal with. So a lot of these folks need to know that they can speak to a physician by audio only on a phone, especially for Medicare and Medi-Cal patients. So with that, that's our basic framework for today. I'm going to pass it over to Dr. David Seigler to speak about this issue. Dr. Seigler, thank you.
Thank you very much. And just to start, I'd like to explain a little bit of my experience with telehealth, just to give you my perspective. I know where I'm coming from. So the partnership that I work with, Vituity, I was one of the original 3 telepsychiatrists for our initial telepsychiatry panel. And when we started to build that service, we were primarily doing psychiatric emergency consults. So people who were brought in on a 5150, maybe in the state of some sort of mental health crisis or intoxication syndrome, something like that. And very specifically in that very small, like kind of narrow piece of medicine, we were able to help a lot of rural hospitals get people where they needed to be, get them the medication that they needed right away, get them started on treatment. Whereas without that, they would be lingering and sitting in emergency rooms, a lot of times even in 4-point restraints, because there was no mental health professional, there was no psychiatrist that could handle these patients. They didn't know what to do. And for our ED docs, who this isn't their specialty, they have heart attacks to deal with, right? They have broken bones to deal with, and they didn't have the bandwidth to work with these patients. So it was actually very fruitful, very rewarding experience, because I felt like Superman. I was able to go in and on a shift, a typical 12-hour shift, I was typically seeing on a busy night about 11, 12 patients in 10 different hospitals. It was actually fantastic because I was able to help people, in Salinas, helping people in San Jose, in San Mateo, as well as, San Diego and Riverside. But by doing this, I could really spread out my catchment area, and we were helping people all over the state. Actually, I forgot, I was also doing it in Oregon. So 2 states, and I think at the very end, right before I joined Arrowhead full time, I was credentialed at 20 different hospitals, which allowed me, well, first, it allowed me to see a lot of patients because, of course, that volume was there, but it also allowed me to help 20 different hospitals with the click of a button. And I was sitting in my home, I wouldn't tell you that it wasn't stressful work. Of course, these are still ED consults. It's the same stuff I would do if I was standing in front of the patient. It's the exact same work. And, of course, the benefit of video conferencing is that I can do a really good mental status exam pretty quickly. I can comment on gait and station even. I can do everything. And, specifically in my field, it makes perfect sense. I don't touch patients, right? Unless I want to shake somebody's hand. But otherwise, I just need to be able to see them, and I need to be able to make quick decisions. And so much of my mental status exam that I do, I can do in seconds, just because, 10,000 hours, do you become an expert? Obviously, this is my thing. This is what I'm good at. but it allowed me to do so much good so quickly. And it led to some really interesting, situations. Like, for example, I was the only psychiatrist in Mammoth Lakes, which is kind of neat. My parents have a home up there. And so I kind of felt like I was giving back to the community that I enjoy so much. And it led to really interesting, fun things too, because I actually learned that there were no mental health hospitals within an hour of Mammoth. And it was actually easier to not put the patient on a hold and send them to Reno and get them their treatment than keep them there and put them on a hold because they couldn't transfer them anywhere. Very, very helpful. Actually, Vituti is continuing to grow with mental health and specifically telemedicine to the point where we're starting an outpatient practice where we will do our initial evaluation in person, but then the rest of it will be done at home, at the patient's home, in our home, for just comfort and ease. We're even talking about doing initial evaluations for TMS and pitch hitting with one another so that we can cover it. That's just more growth though. Here specifically at Arrowhead, my experience with telemedicine has been extremely helpful, especially during the pandemic. The first thing I did was I grabbed literally a dozen iPads because the units are, of course, the perfect formula for spreading of COVID, right? You have a day room where people congregate. Now, granted, I'm very proud to say that we did not have any outbreaks. We were the only mental health hospital that did not have outbreaks. We didn't have to shut anything down. But I think that had to do with all of the things that we did, including using 12 iPads and doing like a mini version of telemedicine. I was here on site. I was available for any emergencies, but there were days where I would literally just zoom down into the units to go see everybody. And it allowed me to not get sick and continue to run the department. And of course, prevented all the patients from getting sick, because actually the person who's most likely to spread it is the guy walking around the hospital, right? So that was really helpful. In addition, I think the telepsychiatry panel has grown so much that I think they were covering 30 hospitals as far east as Indiana. So it's really a wonderful way to get high quality care out to areas where you're just not going to get it. And I really see a lot of benefit, especially in our county, as we're thinking of the high desert, right? Barstow, Apple Valley. If you want high quality physicians, especially psychiatrists, we're not the easiest to manage. In fact, we think that we're easy to manage, and then we're worse because we don't own the fact that we're difficult to manage. So knowing that, expecting someone to drive 90 miles or even 90 minutes each way is not going to happen. Unfortunately, I've seen a lot of people leave the outpatient clinics and are now working for other counties because they want to live in Irvine and they don't want to drive from Irvine to Barstow every day. I don't blame them. I don't want to drive to Barstow every day either. So without embracing telehealth, I see a lot of patients who would be suffering. And, especially in psychiatry, knowing that this is something that I can do, I don't need to touch a patient, own it, do it, right? I do see a couple of questions in the chart, or in the chat, but I think we're going to wait till the end, correct?
Yeah, is that okay with you if we wait till the end?
Absolutely.
Okay.
So with that, I will offer the floor to the next person.
That's great. Thank you so much, Dr. Seigler. All right, let's go ahead and welcome Evangeline and Sophia.
Thanks, Alison. Just pulling up our slides here.
Great.
Okay. All right. Is everyone able to see this?
Yes.
Yes.
Okay, great. All right, well, thanks everyone for being here today. My name is Evangeline, and I'm joined here by my colleague Sophia. We both work for a consulting firm called Guidehouse, and we were brought on by the Riverside County Broadband office about 2 years ago now to help the county implement its broadband master plan. So what we're covering today is a little more zoomed out, looking at, what government is doing. A lot of cities, counties, states are doing this work to expand broadband access for residents, which, ultimately does tie into their access to telehealth. And so we'll be covering kind of a high level, super simplified version of kind of our 3 efforts for the county in expanding access to internet. So this is organized into kind of 3 main focus areas. The first is least directly relevant, but still important to what we're talking about here today. So that is infrastructure deployment. So we are working with internet service providers to support them in applying for funding and standing up different projects that help truly lay the foundation for a more broadband access. As you all know, in the Inland Empire, there are many rural areas that either don't have any access at all to internet, or if they do have internet, their connection, their speeds of internet might be too slow to join an appointment online, and that we want to get all residents to that point where they don't have any issues joining any important appointments via their digital devices. So that's kind of the first bucket. Next is also very important is connecting residents to affordable internet. So we've been talking today about legislation that's really impacting access to telehealth, to telemedicine. There was another federal program called the Affordable Connectivity Program. This unfortunately officially ended on June 1st, but this program previously was giving a kind of discount to low-income families of $30 and up to $75 in tribal areas. And this was for their internet service. So this allowed many homes that didn't have internet before to get connected. And even, for some people covered their entire bill. And that was really helpful for getting them, access to important services like online, schooling during the pandemic and, applying for jobs. And so even though this program has ended, our work is not done with connecting residents to affordable internet. We've now kind of shifted focus to getting residents connected to at least other low-cost internet options. Unfortunately, there's a range here. So some internet service providers are offering really great options that are both low cost and also at the kind of speed and connectivity level that households need if they have many people living in one home. Some are maybe lower cost, but still just not at the kind of level of connectivity that they really need. So we're trying to get the word out and still help residents get signed up for these programs through a call center that actually operates statewide, where they can call and they can get information from trusted members of a nonprofit who then help them get the information they need and get signed up for other programs with the Affordable Connectivity Program ending. The last component of our work with the county is focused on digital inclusion. And so what this means is, we want to get residents the skills and devices that they need to fully use the internet that we're trying to get them connected to. So this looks like working with different programs that already exist in the county. So lots of nonprofits, other county departments, school districts. You'll see Sophia will cover county departments like the Office on Aging that have programs that are trying to help our seniors get the skills that they need to use devices. And so that is what our current focus is on. And, we also are running into in this kind of digital equity space. We're hearing from everyone this issue of funding. A lot of funding is temporary, funded by grants that they have to apply for. You may not always have the resources, the staffing to apply for these grants. So how can we implement kind of a solution to keep funding sustainable for these programs with the, acknowledging that this is not going away, and we see the benefits of having these online services like telemedicine. And so how can we work with, the government and different, local organizations to find a solution where there is, funding that will be sustainable and not just dependent on grants. So that's kind of our current focus, especially with the Affordable Connectivity Program winding down. So we'll be happy to answer any questions you have. I know that was a lot of information, but happy to address those at the end of our presentations. But I'll pass it over to Sophia to kind of share some examples of telehealth initiatives that we're seeing within the county.
Thanks, Evangeline. And it's really great to be here with all of you today and learn about the awesome work that you're doing in your respective fields and regions. So we wanted to share 2 examples of programs that are happening in Riverside County that may be of interest in terms of, using technology for telehealth purposes. And one of the programs is with First 5, which many of you are probably familiar with, where the county provides support for families with young children under the age of 5, as the name implies. And so we're highlighting the Her Care program at Riverside University Health System, which focuses on providing comprehensive multidisciplinary care for expectant mothers who have high-risk pregnancies. Care for mothers could include care for mothers who face a wide range of conditions, which could affect their delivery, such as multiple gestation, birth defects, and issues with addiction. And mothers are able to receive timely and specialized treatment that can include genetic testing, immunotherapy, diabetes education, behavioral health counseling. I think where the telemedicine piece comes into it is that they've started an initiative where, for example, they can send out technicians who have specialized ultrasound equipment that can be used remotely, where they're able to send the technician out, but the actual maternal health specialist may not be able to go out to the homes, but they're still able to kind of see and hear using this telemedicine specialized equipment to then provide this skilled maternal fetal medicine care, which I think Dr. Seigler, you pointed out one of the challenges, which I thought the First 5 program manager just very succinctly described as what you have is a challenge of subspecialists, like some of the super specialist doctors in the cities, and a lot of babies and moms who have these needs in the desert. And so it's hard to connect the two, because there's also transportation challenges sometimes for those households to be able to drive out, if the specialist is over an hour and a half or 2 hours away from them. They may just not be able to receive the care that's needed at the frequency that's needed. So through these services, patients have access to registered nurses, sonographers, patient service coordinators, so a whole host of support from a multidisciplinary team that ensures that the moms and when babies are born, that they're taken care of through every step of the pregnancy, even in remote rural areas. And that's one of the big advantages of having the different telemedicine services. So that's the First 5 program. That's one of the highlights of what they're doing. And then the second example, this is what Evangeline had mentioned, the Senior Learning and Technology Engagement Program, which is abbreviated as SLATE, that Riverside County's Office on Aging is running. It's a 2-month program for seniors that teaches them digital skills that, and I don't know, I think they're provided with a tablet in most cases also. So if they don't have a device, they're able to have both the device and the training to use it to help them complete the program. And the goal of this program is to increase their cognitive skills. And they also really focus on the, like a mental health kind of aspect of trying to reduce loneliness, which I'm sure many of you are aware of is kind of this epidemic that we were probably already facing pre-COVID, but was heightened by the isolation that many people felt during the pandemic. And so they begin with teaching basic skills such as just setting up an email account and then gradually increasing the level of skills, the advancement level. So one of the more advanced skills that participants are taught once they have some of the basic mechanics even of, say, using a device and logging into different applications is how to set up telehealth appointments, which is very important for this population. And so following the end of the program, participants then have the option to still maintain a connection with a peer mentor. And one of the support areas that they focus on is telehealth. So those are two of the programs that we wanted to highlight. It's probably not a comprehensive list of everything happening in terms of telehealth in the county, but we wanted to highlight those two programs. And I did see some questions pop up in the chat, which I think we can answer at the end. And if it's something we can just copy in information for, we'll drop it in the chat. And we'll hand over to our last presenter.
Okay, I think is that
That would
me?
be great. Sorry, I was the usual muted. Yes, you go for it, Maria. Thank you, ladies. That was really awesome. And we're excited to welcome you now, Maria.
Okay, thank you. I'll just go ahead and start off too. I've had experience in schools, in hospitals, in private practice, in locked psychiatric units. But leading up to COVID, it had always been face-to-face, and I was always on the floor, or I was just always face-to-face. And kind of old school thought, I don't know if I'm going to be able to do this telehealth because I read so much body language. I just wasn't sure about it. And then within 2 weeks of figuring out the technology, because we were also being told that we could do Zoom, but then we had to upgrade our Zoom. And then we had to, we went to a different EMR all during COVID. It was a lot of learning fast. But the face-to-face that I still got with the clients, I was using my hearing to see how they're breathing. I was trying to assess the anxiety and the shallow breathing and all that kind of stuff that I did face to face. I'm now just highlighting those senses a little bit more so I could still do it and be productive and helpful to the client. And so that was really a big wave. And then I was helping St. Mary's Medical Group, which is in the high desert, affiliated with St. Mary's Hospital, during COVID, integrating mental health into the primary care, which I think is fantastic because clients don't then have to go outside their medical group. They can just make an appointment with us, or on some cases, I could just walk right over and introduce myself and say, look forward to seeing you next week. Or it was just such a smooth transition when we were face to face. And then COVID hit, and it was a quick pivot. And the doctors were like, what are you doing? We have 10 times more people than you can handle. I'm like, I'm aware of that. I'm working as hard as I can. And my sessions were 45 minutes to an hour. Their sessions were 10 minutes. So it was a lot of change for them too, to understand like how I work. I didn't compromise certain things. I needed to help them also understand how, mental health works and how it's different from their primary care practice. But it was fantastic. Bottom line is we got to see a ton of people. I was able to hire a whole lot more people there. And they all started with telehealth. And our clients, the ones that really did want face-to-face after it was safe, they were welcome to come back into the clinic. But the majority, we are telehealth, and we are audio too for our older ones. So we have that flexibility to do all of that. And I didn't skip a beat. I think in some instances, some of the clients that wouldn't have come in face to face gave it a try on the phone. And there was a whole lot more. Traditionally, women are more up for counseling and telehealth. But my male population grew immensely over COVID. And I think, again, that was a great thing to be able to allow more access in their way of learning or whatever that was. But it still is a lot of people preferring telehealth. And they are conditioned too with the Zooms. But then I'm like, well, do you want to do it on the phone? Because you have to go out in the car to have your own privacy. I'm fine with that. And they're like, oh yeah, that'd be great. At the beginning, we also had to come up with protocols because there was some inappropriate stuff on Zoom that was coming up. So it was a lot of learning during that whole process, but I think overall they really, I mean, I'm hearing that we only have another year or 2 years to have telehealth. That will really surprise me if we cannot continue in that direction, because it is overwhelmingly successful in my experience. Our outcomes are great. I think IEHP has been a real trooper. The private insurances have been okay, but really IEHP has made it, before you had to get your referrals and then wait quite a while. And that was unfortunate because we didn't have enough access. But now that we have more telehealth, there was more access. And IEHP made sure that providers are not keeping their clients waiting so long. Like, you can't have an emergency and get in, I mean, a mental health emergency and wait 6 weeks. That's not acceptable. So IEHP really pushed down on that to providers. And access now, I think there was a question. If you can't get them in 3 days, there's a problem, and there's a whole lot of other people that can get them in. So people shouldn't be waiting that long. IEHP also did where the doctors had to do the referrals. Not anymore. The patient can call in and say, I want to see a counselor like now, and they will literally get 3 names, or the IEHP employee will ask them, do you want me to help you set it up right now? Which is fantastic. So to me, that is really an advancement of where we were before COVID. So telehealth is, to me, just gone in a really positive direction. And yeah, I think access, I think we have to be even more accessible for youth. They would prefer to text, and I'm like, okay, I'm not that fast. I'm really not that fast. So we have to be open to finding them and allowing their way of listening and learning. And the seniors, definitely, they prefer the phone versus the Zoom, several of them. I'm trying to go over, what did I have here? And I love questions, so if people want to put some in, please do so. Challenges was definitely the technology piece. Even in, still today, when we have windstorms or fires or whatnot, our internet is sometimes sporadic. So that does create a bit of a problem for us. But everybody, I think, has gotten patient with, we'll call back. I've already, my protocol is, where are you? Are you in a safe spot? And all this kind of stuff before we get going, so I know where they're at. If we get disconnected, I will call you back. And if that doesn't work, I will text you so that they know we're not just, she doesn't care. We're done. So those kind of policies too help, I think, when we set up for technology issues. And then privacy is a really big one. I want my folks to be able to talk freely and then have boundaries as well. Like, we don't need the whole house hearing everything. So that flexibility to go in the car, the flexibility to take a walk and talk at the same time is wonderful. Let's see, what else? I'm sure there's got to be some questions.
That's fantastic, Maria. This is all really fascinating. So would you like us to go on to questions now?
I love questions. Yes.
Okay. Well, everybody, that was just really interesting, and hearing all your different perspectives. So we do have quite a few questions. So Soteria, would you like to go ahead and get started with Angela's first question?
Yes. Let me see. Hold on. I gotta scroll. Okay. Are there any organizations doing behavioral health street medicine in collaboration with any CBOs combined with outreach and engagement programs in the county?
I'm working with the Simba Center, which just opened a homeless shelter in Victorville. They do street medicine and they are hoping to take it down the hill into San Bernardino. I think Kevin might have put a link in there also of some other agencies that are doing street medicine. And I really think that that's a positive thing that's coming that we're going to be able to get reimbursed for. So more people can start doing that. Talking about meeting the people where they're at. It's really important. So thanks whoever asked that question.
Yeah, and Kevin's comment, you're right, that's really, thanks, Kevin. He said the County of San Bernardino Department of Behavioral Health has a program named Inroads. Inroads goes on the streets and tries to provide folks injectable medication and encourage them to start treatment. Wow, that's amazing.
LA has quite a few that are doing it. So I'm hoping that San Bernardino and Riverside are going to see the value of these street medicine. I mean, they're helping folks physically and mentally out there just heal, let alone, it's so basic, like a cut can turn into this massive infection. But if somebody comes every week and treats that cut, maybe we can get then into like finding you housing, finding you other things. But if they're just oozing with icky stuff coming out of their body, it's really hard to get to some of the other stuff. So I'm a big fan of street medicine.
Awesome. It's good to know. Great. All right, Soteria, go ahead.
Okay, can the advocacy process for the current federal bills be sent out to all attendees?
Yes, Ms. Victoria, I will be glad to share that. And I think I can probably obtain some additional information from a couple of other experts at the California Medical Association that is going to continue to keep us updated on that. So it's a great suggestion, especially to track where these bills are. You know, we talked about the one passed the House Ways and Means Committee, but we need to know where it's going as far as permanent adoption, and is this going to be extended to 2026? So we need to see if this is going to be passed by the full House. What are the current advocacy efforts? You know, what are the coalitions involved in lobbying for this? So yeah, we'll definitely send that out. Thanks for asking that.
Okay, the next question, how fast are the response rates with those reaching out telemedicine compared to walking into a center for assistance or treatment?
I can speak to my piece. I'm sure the doctor will want to speak to a different piece. So primary care now, because of telehealth, usually you can get in pretty quick. And again, it depends on which doctor's office is. But the county also has been pushed hard to not have these enormous wait times. And if you hit trouble with those doctors, I mean, you can call the insurance and say, look, is there a list? Can I just call myself and get in? And they'll give, like IECHI will give patients their referral number. And here, it's 26 visits. Who can you get in with? So it's wonderful. I think that there was another piece to that question I forgot. Sorry.
Oh, okay. It said, how fast are the response rates with those reaching out telemedicine compared to walking into a center for assistance or treatment?
Well, walk-ins, I mean, the High Desert Walk-in Center, they're going to walk in, but I don't know how busy they are on that day. And that's the crisis walk-in versus a counseling center. Again, it's a 3-day thing is what we're supposed to be aiming for. So that is the goal. Not everybody, you know, some places still have quite a wait list because they just don't have enough people, but don't get trapped. Just keep advocating for people to get in quickly. And there's multiple ways to get in now, through your insurance, through your doctor, through Psychology Today. You can go on there and see who takes your insurance. So there's, you can Google even. There's,
Right.
Great. Dr.
And just-
Seigler, did you have any thoughts on that as far as walk-ins and how, because I know being part of the ER department at ARMC, I'm sure you deal with that too.
So actually, I'll just state the actual facts. Patients that are leaving Arrowhead from the Behavioral Health Center, they may get in with a physician. They are going to be lucky to get in with a physician within 70 days.
70?
Yes.
Oh,
Whoa.
no.
So I think that we very much need to embrace telehealth, but we have not. And one of the questions I believe down was that Maria already answered from her perspective was what's one of the biggest challenges. And I truly think that culture is actually a big challenge because I'm watching physicians leave because they're being told, you got to drive to a clinic and do telehealth from your office so that I can watch you
Right.
instead of doing telehealth at home. So instead they quit and they go work for San Mateo County, right? It's a huge problem. And it's something that really needs to be embraced, 100%. You can't do it halfway. If you do it halfway, you just end up with really frustrated physicians. Because now not only do I have to come in and deal with the drive, but I'm still doing it via teleconferencing. That doesn't add up.
Yeah.
So I think
Right.
that's the cultural problem.
I think that, and that's one of these things, I think if I read the bills correctly, H261 and 7623, those are going to modernize this. Hopefully, if we can get them to pass now, but those remove the site restrictions, the geographic restrictions, so that they don't have to drive into a clinic. And then, like you say, how stupid, how ridiculous to have to go into the clinic and then do the telehealth visit from there. That defeats the whole point of this. And it speaks to the need for us to all, whether it's through our organizations or us individually, to really reach out to our congressional representatives to try to get these things passed. They have to know that people are paying attention to these bills. So we'll send this out, but the advocacy matters. You gotta jump into this and write your legislators and try to meet with them while they're here in the district. Try to meet with them, go in and see them. I think we also missed a quick question here. There was a question from Angelo about mental health treatment or medicated assisted treatment, and it was related to the street medicine question. Angelo, could you explain that a little bit? Does anyone have any MAT treatment protocols related to mental health?
I mean, it's certainly possible. Again, now we're even talking about a harder subspecialty beyond my specialty, right? With addictionologists, and you can do a Suboxone induction over video conferencing. It's not hard to do. I haven't done one myself because I haven't taken my test yet, but I have intention of doing it. And I do think that it's absolutely easy to do. The only caveat to that is you're going to need support, because you're going to need someone on the other end able to get vitals and do those kind of things. But if you've already got someone bringing a device to that patient, if you're doing it in street medicine, someone's coming to approach that patient. So if you already got somebody doing it, you can also have them dispensing medication while you're working with them.
Wow.
So in LA, they're definitely doing that. And it's a team. They don't go out by themselves. There's three. There's usually the nurse practitioner, the case manager, and the mental health person. So I like that multidisciplinary approach. And they, just start to engage and see where they're at, because the nurse practitioner is fixing wounds and the other person is able to, with the tablet, call in and get their prescription, their psychotropic medications renewed, right? Because some of them know what they used to be on, or it's really wonderful when it works ideal. But then they've moved or they're gone, and then it's really hard to start back over. But they are finding a different tracking center, and this is a tech thing, I think, issue that if we had it more broad, say they went from LA County to San Bernardino County, could we see what medication they were on? Could we help them more? Because there is a lot of inter-district transit. But that's not the case yet. So that's why it gets slowed down. And, you know, some people just don't get their insurance because they move to a different county, and then they get homeless again, and it's really hard. So there's a lot of other things that go into the street medicine with the case manager and those three that can really help them. Because a lot of times when they get to another county and it didn't work out the way they thought, they don't know how to access all the stuff. So I hope that answered your question.
Just to add to
Right.
that too, I'm very, very hopeful with, you know, the modern EMRs. I mean, right now, if I bring up Epic, I can see every encounter at RUHS, Loma Linda, UCI, what have you, through the Care Everywhere program. And it's fantastic because I don't have to worry about it anymore. And so I think as all of the EMRs, not just Epic, although I am a fan of that particular one, and I think as they all get better and they start talking to one another, we'll see less of that. And I'm very hopeful that it'll just continue to get better, because it already is.
Yes, I agree. Epic is the most widely used one that I can see too, with all the counties. But not all the doctor's offices, not all the, even the federally qualified, I think they're having to go there, but not all of them have transitioned yet. So it's another thing to think about.
Yeah, and Epic, yeah, it's amazing, but it's a little harder for smaller practices, I think, to get onboarded onto that. Before we force you continue, Soteria, I see Dr. Michael Secura, our public health officer, is on the line with us for San Bernardino County, and his hand has been raised for a while. Dr. Secura, do you have a question or a comment?
Hi, I've just been sitting and listening and learning, but I just wanted to. I thought I could add a few things. One with this specific regard to MAT. You know, Dr. Seigler had made some mention about the X waiver for buprenorphine induction. Well, we actually managed through advocacy to remove that X waiver requirement, and so what we're working with now, especially in some of our more distant regions like Morongo, is working with our community health workers and with some of our organizations, our community-based organizations. We're doing a combined substance use navigation and community health worker, and actually being able to do primary care inductions and with buprenorphine. It's just a specific art, because it's different when in this age of fentanyl, but because it's difficult to do a primary induction in a patient who's chronically on fentanyl, because it's dissolved in the fats and it takes a while. But working with primary care physicians and with community health workers, we're starting to do that. And the other thing we're looking at is EMS protocols as well. But the other thing I wanted to add is, I don't know whether you all are aware that is a Children and Youth Behavioral Health Initiative that by DHCS. It's a $4.6 billion program aimed at the behavioral health of our children. And you know, it's a severe big issue. Our adolescent suicide rates are up 300% over the last 2.5 years. And in the theme of this meeting, they've released 2 new apps and coaching programs, wellness coaching programs for children. One's called Bright Life Kids, and it's for kids 0 to 12, and they're free. And and the other one's for ages 13 to 25. It's called Soluna, Soluna, and they're free apps, and they give access to free coaching to children, and care navigation. So it's they've just been released, and they currently have the app for Apple, and they're developing one for the Android app as well. So there's a lot coming along these same lines with regard to telemedicine and reaching out to to kids from a behavioral health standpoint. So thank you.
Thanks, Dr. Secura. That's, by the way, if any of you, just a plug here, but sometime you all have to tune in to one of Dr. Secura's updates about opioid substance use disorder and opioid use disorder and fentanyl and all these other public health concerns and crises. It's really fascinating presentation. So we'll hope to schedule one of those with you again soon, Dr. Secura, because it's of interest to everybody. So thanks. Okay, so Daria, I'll shut up now and you can continue with the questions.
Oh, you're fine. Victoria asked the question, can we get the broadband support contact info to give to our clients? So Evangeline went ahead and just added the website and a telephone number there into the chat, answering that question. And then Alison asked the question for Dr. Seigler and Maria. What are some of the greatest challenges you find in providing telehealth, whether related to patient experiences or limitations within the system?
Who wants to go first?
And I think my attempt was to address this one a little bit already, where I talked about culture and how people, you got to either dive in and do it or don't do it. And I truly think that people need to understand that. One of the ways that I have been able to successfully beat that was operating on a slight hybrid model for kind of an introductory period. When I helped out in Salinas for Natividad, what I specifically did is I went up there for two to three weekends in a row, covering their ED and doing consults for them. Made relationships, got everybody to know me, got my social work team comfortable with me. When we got to the point where I knew what their coffee order was, I knew I was good. And once I had that kind of relationship with them, suddenly I could do shifts in my home in Riverside, and they would call me at the beginning of my shift and they'd say, okay, we've got 3 people, but 2 more are coming. Why don't you wait a half an hour and we'll get all ready for you, and then we can bring the robot through for you, and then you can just focus on your documentation for the rest of your shift. And so I was then able to see 5 to 8 patients in 2 hours, and then just spend the last of my shift just finishing my documentation, getting things together. Yeah, it's a solid brick of work, but that block was going to be there one way or another, whether I was in Salinas or in Riverside. But I got through the hurdle of, oh, it's a guy on a screen and we don't know him. And after I got through that, it was not a problem.
Dr. Seigler, do you find there are, I don't want to say administrators, but say folks within maybe management levels or whatever who are reluctant to advance this type of patient care, and maybe that's because they're not understanding how effective it is or things like that? Or do you find that?
I don't think it's about effectiveness. I think it's about control. I think it's truly like, I want to make sure that this person has their body in the chair from the hours of 8 a.m. to 5 p.m. Otherwise, I'm not going to be happy. Whereas, I mean, actually, it's kind of silly and kind of fun, but one of my hobbies is baking. And I developed this hobby during my tele shifts because you have downtime, right? You have downtime between consults. We all have downtime in the hospital anyway, right? We're just playing on Instagram, waiting for the next patient to come in. But I'm at home. I don't want to get invested in a book or a video game or something like that. But instead, you can mix up a batch of cookies, throw them in the fridge, and go see another consult, and then put them in the oven between the next one. it actually
Love it. Love
a
that.
wonderful work-life balance and gives you a lot of flexibility while still delivering that care, which means I worked more, which meant I cared for even more patients because I enjoyed my day while while seeing patients because I had my downtime. I was able to do those little things in between consults because I wasn't stuck in my office.
I mean, I so am a fan of that. I can't even tell you, you're happier, you're more productive, you're accomplishing more. Yeah, and there's a better balance. So thanks. That's really interesting. Good perspective. Okay.
So I'm going to go upstream a little bit more because I think that if we could still advocate for our physicians in private practice or group settings, whatever, take a little bit more serious look at mental health. Because when I approach doctors, you just talk. And I'm like, yes, but I have intention and there is a goal and there is a way in which I'm doing this. It's called cognitive behavioral therapy, for a reason. And I really had to prove in certain situations how mental health can help their clients because they'll just give them a pill. You know what I mean? And I think that it works great for some, and some people might not need that pill. If we can teach them some more tools on how to deal with their anxiety or their depression. So one funny one, this was a good one. So one of the doctors was like, how are you going to help me? Because I'm not referring to you. I was in this practice with them all. I'm like, okay, well, who's one of your highest? So if their blood pressure is too high, they're not allowed to let their clients leave until the blood pressure comes down. And I said, is there anybody in here that's got high blood pressure that you can't get to leave right now? And he's like, yeah, I got two sitting in over there. And I'm like, well, let me go talk to them for just a few minutes. And then I bet you they'll be ready to go. You could take their blood pressure again. And thank goodness I did a little introduction, talked to them. Within 5 minutes, we did some deep breathing. And I said, well, do you mind if they come and just check your blood pressure again? Because we really want to make sure that you have, a better way of breathing and that you'll be able to see me and we'll be able to find you some tools. Sure enough, both of those. And then he did it like 2 more times that day. And all of those clients were able to leave a lot quicker, a lot happier. And so I think I won him over, and he was a regular referrer. And I just thought it was so much easier for the patients too that are like a little bit anxious. There was a lot of grief during the pandemic, and a lot of primary cares didn't know is that a mental health? I think it's just grief, but they need somebody to talk to. And I'm like, that's a perfect candidate. Look, you don't have to have because they're like, I don't want to diagnose them. I'm like, you don't have to. You can use an adjustment. You can use unspecific. There's all kinds of ways to get them over so I can see them. Oh, so just that little bit, if we could help our primary care doctors understand how to refer a little gentler to mental health, maybe we'll keep some out of the ER. That's my hope, is that we can just get people more tools to manage their symptoms and then understand them and then just heal. Because 70 days is not a good thing waiting once you get out of a hospital. So yeah, I hope that answered so that was one of the good things of setting up behavioral health practice inside of a primary. It was a win for the patients, it was a win for the doctor, and a win for me. I think some of the hardest ones were, well, it still is, because sometimes mental health is when there's a destructive behavior going on, and you're doing everything to try to help them see it, not tell them what to do, but see it. And they choose not to go down the healthier road. You always hope that I'll see you again when you're ready, or, so those are the hard ones. Since I was first starting out, they still are kind of hard when you have to terminate early with somebody because they're not in a place to really want to do this. So hope that answered your questions.
Wow, I find this fascinating. Thank you. Okay.
And so Alison asked the question to Evangeline and Sophia, do you work with IHP and Melina to offer some support services, such as what you do with First Five Riverside to assist clients? And the response back was, we actually have not been connected with anyone at IHP or Melina yet.
So maybe we could, let's talk offline, ladies, so we could, I mean, I want to make sure they're aware of these programs, and you have piloted it with First Five Riverside. So I think if they don't already know about it, they'd be super interested in this, perhaps. I don't know if anyone from on the line, I don't want to speak for IHP or Melina, but I'm just wanting to be a convener here. So, all right.
They do have something that's called, oh, can't remember the name of it. IHP, that is. I don't know about Melina, but they are trying to make sure that the new moms are getting more resources. But I don't know how that is getting passed down to the clients. Sorry.
Great. Okay.
The next question is, Dr. Seigler Maria, is anyone documenting the success of mental health through telehealth so we have the data to support the need for the infrastructure and fiscal support?
Yeah, absolutely. Just my partnership alone, we've tracked how many consults we've seen. We have statistics on how many people went home, how many people are staying, how it shortened their care, or I'm sorry, shortened their stay. But there's a mountain of evidence on the successes of telehealth and how it doesn't affect it. Everyone was worried that it would affect care, but it doesn't affect care in a negative in any way, shape, or form. It only enhances it because it allows for a greater kind of zone that I can hit. And all of the data, everything that's been shown in PubMed is only positive and supportive.
So I have two thoughts on it. Definitely, I have to track. It's best practices. We test when they come in. We test within 3 to 6 months, and we're assessing their depression, their anxiety, PTSD, whatever the symptoms are that they're coming in. So individually, we're testing. Insurance companies want to know that. They see the diagnosis, so they're tracking it. Lots of people are tracking it. But here's my negative side to it. There are some I'm calling them pop-up mental health tech companies that are assessing almost every time the patient comes to talk to somebody. That is not cool in my arena, because I've had lots of people say, why do I have to do that every time? I have to think about all the stuff that has happened to me. And it just makes me more depressed. I'm not going to show any growth if I have to keep taking those. And I'm like, well, I think they're working on different ways and timeframes to have those. And then I just basically say, you won't have to do it that much with me ever. So I think we have to come to some kind of balance on this as well, because every week you are not going to help your client if you're asking the same questions, but I understand where the funders are needing data. And we do want to show that it helps, but I'm always about patient healing. People are quiet out there. What happened?
Maria, that's interesting. I think that's been one of the concerns for some of our medical groups too, is that when you have a lot of these pop-up, frankly, pop-up telemedicine providers that are not tied to a more stable long-term primary care practice and that sort of thing, it can result in a lot of splintering of efforts, and that's a bit of a concern. And I think maybe I don't know, maybe it's just kind of the Wild West out there right now with this happening. So there has to be kind of some standardization involved, maybe. And I don't know, maybe Dr. Seigler has an opinion on those.
Yeah, I do. And just like what Maria was saying, it's not what she just described to me I understand it is, I know it's data collection, but at the same time, that's also just bad therapy, right? If you, there's plenty of medical spas that are selling, Botox and weight loss medications to people who may not need it. And I understand that some of those things are in vogue, but that's also kind of flash in the pan. It's hip right now, right? Just like there's a lot of companies right now that are doing telemedicine and handing out stimulant prescriptions inappropriately. Because then it's a problem. But people were still doing that before telemedicine, right? So just like everything else, it's a buyer beware, right? You want to make sure you're going somewhere with a physician or a care provider that you trust, and you can develop that trust via video conferencing. That's not a problem. It's just that very specific kind of thing is occurring all over the place, but it's simply not good care. But it has nothing to do with the telemedicine model. They would have done it in a brick and mortar just as easily. Those things exist, and it's just part of the field. I pride myself in the fact that I only prescribe it. I get asked for it all the time, but I only prescribe medications that I think are going to be helpful for the patient for that specific diagnosis and their behavior. Not everybody does that, and unfortunately, that's just the world we live in.
What do you mean not everybody does that? You mean sometimes people will just prescribe stuff because they're asked for it?
Yeah.
Basically, yeah.
Exactly. I mean, I won't name names of any corporations, but you can go on social media right now, click a few buttons and apply and be set up with a telehealth appointment. And you can start by saying, I started this telehealth appointment so that you can start me on Adderall. Oh, okay. And then the entire conversation is about attention. And they're going to ask very pointed questions so that they can justify the prescription. But those things do happen, and that's not good behavior. I don't commend that, but it is the real world. And some people choose to do that.
Wow. Interesting. Okay.
There's
Thank you.
also so many behavioral health pop-ups that are changing the way we do business as well, with 30-minute sessions, with some are having a consistent therapist, some are not having consistent therapists. Some people are starting mental health counseling in a way that's so different from what it used to be, and they don't know that they could do better in some areas. That's the thing that I hope gets more educated for the consumers.
Wow. Okay. Thank you.
Hey, and the next question is also from Victoria. Are there any programs to support youth receiving MH services through telehealth? And Evangeline did answer. It says there are a few different programs within Riverside County that could be helpful to youth looking for digital skills training or access to devices. We have a list and a map on the Riverside County website, and then she also provided the link if you want to take a look.
Great.
And the next question is, you spoke about having more med clients post-COVID. Do we think this will stop when telehealth stops? What do you think is the reason men are more likely to via telehealth?
I don't know if it will stop if telehealth goes away, because I think it is more acceptable now, counseling. I mean, like, that stigma is definitely starting to go away, and it's almost hip for some people to go to a counselor. So I'm not sure that it will go down. And what was the first part of that question?
Oh, I apologize. Let's see. It says, are there any programs to support youth receiving MH services through telehealth? No, that's
Well,
not.
I think that
apologize.
question was, you spoke about having more men clients post-COVID.
Yes, I apologize. Yes.
So I don't think it'll go down. No, but the flexibility before, again, remember, most mental health were from like 8 to 5. Well, now there's a lot more after work too. And there were, you know, they're not supposed to be driving and talking to us. They're supposed to be parked somewhere safe, stable, whatever. But I think some may have not told me the truth because I heard cars passing, you know, but is that car parked or not? But again, I think the flexibility of, I mean, I could hear people smoking their cigarette too. They wouldn't be able to do that in my office. It's been a different kind of thing that I think made people more comfortable in their own environment and have more control over their stuff. So they were a little more open to asking for suggestions or thoughts, and they're very good at challenging. Like, why would you say that? And great question. Let me tell you the 3 reasons, you know? And they're like, oh, I would have never thought of it that way. So, well, that's in those kind of ways we get to model also different behaviors of how they can ask questions that are a little challenging to a loved one or whatnot without it being so aggressive or certain tones, you know.
Right. Are they more likely to, so you're saying they're more likely to ask things maybe in telehealth that they would not in person? Is that what you're saying?
I think that has been a little, well, I've seen them in both areas, right? But I think I've seen more people squeezing therapy in between their work and even going out for lunch to take a call, and they're just like ready to ask, let's get to the point, right? So I think that's a good thing. And that's why I think that if we can keep access, we can keep telehealth, and we can keep flexibility, I think we'll be able to continue to see more people.
Like harm reduction, right? Meet them where they're at, maybe. I don't know. Possibly, yeah. Okay. Sorry, Sophia. Yeah.
Oh, no, you're good. You're good.
Okay.
I think this is actually one of the last questions. This is from Alison. Is SLATE something we could make available to seniors enrolling in Medicare and Medi-Cal? How are they eligible? And again, there's another response in here from Evangeline. The Office of Aging prefers for participants to be residents of Riverside County and or members of their organization, but they will allow anyone over the age of 60 to participate. They do not have a page about the program on their website, but interested folks can call the Office of Aging, and there's a telephone number and then a link provided as well.
So, Victoria and Tiffany, we should definitely maybe follow up on that for some of the IECHI clients. That would be interesting. And those are great resources. That's a wonderful program. We really appreciate it.
And that's all that I show.
Yeah. Does anyone else have any comments that you want to ask or speak about? No. We have the experts here. This is our chance. Okay. Well, listen, that was really, really fun. That was kind of a cool way we did that today. It became more conversational, and I love that. And all of you as presenters, you're just amazing. Dr. Seigler, Evangeline, Sophia, Maria, you guys are just superstars, and thank you so much. And we'll follow up on some of these things, sending out some of the information we talked about. So thank you all for supporting the IECHI. We will be having our next health education forum. They are quarterly, so the next one, stay tuned. In about 3 months, we'll be announcing the date and the topic. And of course, in January, we'll have our legislative forum, our annual event. So we'll be starting to work on that soon. So keep in touch with our Facebook page so you can see all those wonderful announcements, and let us know if you guys need anything in the meantime. And thank you all so much for joining. Have a wonderful rest of your week, and a lovely June 19th or Juneteenth tomorrow.
Thank you.
All right. Thank you so much. Bye-bye.